Let's talk about the management of allergic rhinitis. Thank you very much. Pleasure to be here. You know how to identify allergic rhinitis. Sometimes we actually have to do work because patients don't even know they've got it. I love Whiskey-Focken's term of nasal neglect. People just aren't aware that they're doing it. It becomes their new normal. So sometimes we've got to go in there. Sensitisation, just because they show up on a blood test or a skin test, does not mean they've got allergy and that we have to treat it. And if we treat it using some of our therapies, they may not get the results that we need. And there are new treatment algorithms that are present that we should be aware of. So rhinitis is a response to threat. I love engaging patients because that gets treatment. And patients don't like being told they've got a weak immune system. They've got a good one. They've got a great immune system. It's just dysfunctional. It's too good. And so that fight, that augmented response in the nasal airways results in mucus being made to trap a threat, destroy the threat, not let it get to the lower airways. And as we get more allergic, that response gets better. Great if they'd be allergic to crocodiles or elephants. That might be represent real danger, but dust mite or grass pollens, no. But it causes people terrible quality of life. As Janet's already highlighted, we make lots of mucus, up to 2 litres a day in our nose. And the nose is frontline for detection of inhaled threats, whether they be allergens or irritants. And there's 100 million molecules per breath that we have to actually detect and respond to. And the nose is very much frontline, has many receptors to do that. Richard's shown you what allergic and non-allergic noses look like, so I'll swip through that. The common allergens that we have: cats, dogs, feathers, moulds, trees, grasses, weeds. We should all be able to pick those up pretty easily. Dust mite is the most common one, and one of the calling cards of dust mite allergy is somebody waking up with symptoms first thing in the morning. So our biggest exposure to dust mite is in our bed. So we breathe that in. How do we reduce dust mite down? It's pretty tough. We can do things. Once we get over 403 count, our skin doesn't go into the bed. We hot wash the sheets. It breaks down these little critters. Eucalyptus can break them down. One of the exciting things for teenagers is studies that suggest that if you don't make your bed, you get 40% less dust mites. So the dust mites like dark, warmth and humidity. So if you're sweating, that's where they'll be. You pull the doona up, it's dark, romantic, warm. They breed, they eat the skin, and they replicate. But there's about 1 million dust mites in the bed. So hot washing your sheets, more than 400 count covers, and there's encasings that you can hot wash as well. Allergies, are they present? We're going to be talking about localised IgN. Sometimes when the allergens get present, we breathe them in, we can initiate that response in the nasal airways, and there's evidence of IgE being made in the nasal airways, and it may not tip over, so we can measure in the blood and the skin. So our measurement in the blood and the skin are really proxies for what's happening at another site. Same as measurement of food allergies are proxies for what's happening in the gut. If we've got somebody showing up on a skin test or a blood test, it's important to see, is it relevant to the timing of the symptoms. So somebody, I'll see patients with birch allergy, go back, not that I normally test for it, but I'll test it if I've got oral allergy syndrome. In Queensland, we don't have much birch, so I'm rarely going to do birch pollen immunotherapy. So is it relevant to the allergens they're being exposed to? Do they have timing of symptoms? If they don't have a cat, I'm not going to do immunotherapy if they've got a cat unless they're around cats and get symptoms. So just because they're sensitised, it doesn't mean that they've got a disease related to that. So a lot of people will make a bit of allergy against dust mite and have minimal symptoms. So we've got to have a bit of engagement with them and don't treat numbers. And are they exposed to it in a meaningful way? Many patients in New South Wales will have plantain allergy. That's a big, heavy pollen. It doesn't spread very far. So it's in some mixtures. But if you're mowing the lawn, yep, it'll get in your face. If you're rolling around the grass a lot, it'll get in your face. If you're doing office work, no. It doesn't travel terribly far. So you sort of have to think of exposure and symptoms when thinking about how we're going to treat them and give advice about allergen reduction. So that was retrospective. And many patients have mixed rhinitis as well as non-allergic rhinitis. So these are the irritant triggers that people will have. Jonathan Bernstein's really described that well in an open access article. And again, there's a whole seminar on session on non-allergic rhinitis that I won't cut into too much. But think about medications as well. Medications do cause rhinitis, and rhinitis is just the tip of the iceberg. Comorbidities is so 2018, it's multi-morbidities. This sort of affects how we breathe, and it affects our ears, our eyes, our nose, the way our face grows, how we function, workplace presenteeism and absenteeism, as Janet's beautifully explained, strong relationships with the lower airways. There's a lovely, Waldo Tubo has a lovely law, Tubo's first law, saying everything is related to everything else, but the closer they are, the more likely they are to be related to each other. That's the first law of geography, but it actually applies to the nose and the sinuses and the eyes and the brain and the lungs. So, but yes, they do, and the jaw, so they do relate. And the treatment that we do is we try and work out what people are allergic to, is it relevant, how to reduce it. Saline has become very much a part of washing the allergen away and our excessive response to it away. It's better to put a medication on a clean surface than on a mucoid surface. We've got a range of first-line agents: oral antihistamines, topical antihistamines, topical steroids, mast cell stabilising agents, leukotriene antagonists. And the one thing that I'd stress to you as health professionals is that we need to take control. When patients go and do shopping for their medicines, the first-line treatment at the pharmacy is an antihistamine. Second line treatment, antihistamine, then an antihistamine. And you get told, oh, it must have worn off, it must try a different brand. The antihistamines will improve nasal symptoms by 7 to 8%. 7 to 8%. Not what the TV ads suggest. They will work a little bit quicker than some nasal sprays, so yes, they're there. 20% of nasal sprays sold in Australia over the counter are decongestants for use 2 to 3 days, but they've been used long term. 40% of eye drops being used are alpha agonist, oxymetazoline-like. So we're getting it wrong at the front line. We know from the meta-analysis done by John Weiner and Robert Pye and Mike Abrahams 20 years ago, nasal steroids should be the first line treatment for rhinitis. Immunotherapy is very much part of our domain, and we've seen big changes in immunotherapy. We've seen tablet forms, liquid forms. We've got now forms where you can build up to top dose in day one, which are a lot safer than the forms we used to have, or very quickly. We reserve that for our patients who we have allergen reduction and medications are failing, or they don't want to be on it. And to put it simply, immunotherapy is giving you small amounts of what you're allergic to, and it retrains the body to think it's part of you. It doesn't react. Getting a little bit more molecular, it stimulates the production of allergen-specific IgA and IgG4. What's so good about those? They actually have non-complement binding tails. So they'll get close to the mucosal surface. They're quite soluble. We'll get to mucosal surfaces, and they'll actually act as a sponge. They'll mop up allergen. Less will go through to sensitized IgE cells, or cells bearing IgE with a high affinity receptor, so there'll be less allergic response. And over time, we do get some reduction in IgE, but not always. So we might do a skin prick test at the end of it and still have a big skin prick test, but we look at symptoms. So it's important to get your patient symptom scores. We do get changes in Tregs, T regulatory cells as well. And we can get some reduction in IgE production. We do see that disappear. And Connie's going to be talking about the top end of that scale. Ray has always said, where's surgery? So I put this in for Ray, and he's not here to see it. So tell him I put in surgery. And that's a great part of doing rhinoscopy and decongesting. There can be chronic fibrosis. There can be surgical things. So it's crazy to be giving 3 years of immunotherapy if somebody's got a collapsing nasal valve or nasal polyps, or they've had such horrible rhinitis. There's actually fibrosis. It doesn't change much with decongestion. If it's not changing, you're going to be sending them off to your ENT colleagues as well. ASCIA, which is the Allergy Society, have an allergic rhinitis management plan. I tend to, if I'm starting patients on immunotherapy, I'll actually VAS scale them, medication scale them, look at their ocular symptom scores, whether they think it's allergic or non-allergic at the start of it, because we'll often see that change during the course of treatment as well. And if we're doing immunotherapy, we have a baseline requirement to check that they haven't got underlying asthma before we start immunotherapy. Guidelines, and again, the copies are out in the area out here, of the assessment and control in untreated patients. If you've got a visual analog scale, and these are very accurate and have good reliability and reproducibility, initiate any first-line treatment. I'd always say nasal steroids work better than antihistamines, but some patients want a quick response. And if it's more than 5 to 10, they're saying definitely put them on a steroid or a steroid plus azolastine, and reassess them how they're going in 7 to 14 days. If it's still up, they're going to need some help with it if there's no improvement within a couple of weeks. If it's doing fine, stay there, step down to other medications as well, which are cheaper for the patients. And a very similar treatment algorithm exists for the similar patients who are already treated. Just step up, make sure they're taking it properly. Practical points, and I'm sure you've got these complex instructions about how to use nasal sprays and how to have virtual human origami about C positions. They've got cilia that sweep mucosa, so really you do not need to spray it straight back into the back of your nasopharynx. Don't spray it out to the lateral wall so it drills out. Just gently out to the side, outside, change position a little bit so you're not getting this jet in the same place. And I had an educator tell me when he was doing patient training, he actually used the term mush. Australians know what mushing is. In the dictionary, it's a way of encouraging huskies to go faster, but we mush our bread into our gravies. You squeeze it there, it gently spreads out, doesn't dribble out as much, and we rely on ciliary action, it'll sweep it over the turbinates. So it's just a useful technique. We don't have to get into crazy positions. And just thought I'd mention, you're going to hear about this in the news in the next couple of months. Basically, hen egg fed to cats contain anti-FeLD1 immunoglobulin Y, and it neutralises FeLD in the saliva. There's no such thing as a hypoallergenic cat, unless you've actually given it lots of atropine to get rid of its saliva, and it's got no butt because it gets secreted from its salivary glands. So this was presented to Yaki about 8 weeks ago, and when they this antibody will bind to FeLD1, which is a small molecule, and it cut down levels by 47% by 3 weeks. So, but cat allergen will stay around for several months. We want to see what this is doing in 6 months' time, 12 months' time. At the moment, it brings it down by half, which means, okay, I've got 1 cat in my house instead of 2. So it's interesting. You're going to hear about it, and I just sort of throw that in part of the treatment. So without that, I'll just say that's what the goals were, and hopefully I've covered them. Thank you very much.